so both remotely or in presence. So it is a pleasure to be in this very wonderful place. So you can now see well, more remote, but we are in Aula Magna, the LOIUS, so the University School of Advanced Study here in Pavia, la Sala del Cammino del Palazzo del Broletto, so an historical place. This is the first meeting of the signature consortium, so entirely dedicated to discuss together which is the state of the art in the clinical neuropsychology of social cognition, and then also to trying to understand what the experimental neuropsychology can tell us to improve our clinical practice. So before starting, of course, this full agenda, so I have to thank the International Brain Research Organization, so the IBRO organization that found this workshop, so these 2 days, and allowed to host some of you here. So, and of course, to organize some activities here in presence. It is something really good in this time. And also, I think that the special thank is for the representative of patient organization that so are the Italian ones, so the Italian Association of Frontotemporal Disease and also Federazione Alzheimer Italia, that joined the consortium as members, and the Greek and the Netherlands Association, the Greek Alzheimer's Association, and the Netherlands FTD Association. So it is very important for us being here as a community involving clinicians, researchers, and also the stakeholders, so the representative of patients of their voice. So more importantly, I have to thank Alessandra, so who believed with me on the initiative, of course, and gave also her time during this very stressful time, and she knows, but with enthusiasm and dedication. So thank you. So organizing this event for me was an amazing experience. I think that we are a young community. Of course, with people that know each other just for a few months or for a few years. And the most important thing, in my opinion, is trust. Is that we have to trust in a project or in different paths of this project together. And I think that when we joined this community, so we did such an act of mutual trust. We must keep this promise step by step in order to reach some of the outcome that we want to have. But we realize that we are not alone. Of course, we cannot do, we can try to do our best alone as a group, so as a single group, but we have to share. Our effort to reach something that is of impact for everyone, of course. Otherwise, it's something not so relevant or relevant just for some specific context, some specific setting. So. I hope that we can try to put in place so our different backgrounds, different expertise, different perspective, also to reach something that is for the collective benefit. Some times ago, I was at a conference, some months ago, not so many times ago, a conference on open science, and a colleague from the CIMEC, so Carlo Minossi, so mentioned this initiative as a sort of startup in the open science initiative in neuropsychology. And I think that I would like to think that that's what we are. And we have to nurture this evil. And this is the first step. Certainly in the biomarker era, I think that so we have to, there is a strong need of talk about neuropsychology and about create common neuropsychology initiative because experimental neuropsychology, in my opinion, especially in social cognition, it's impressive, but sometimes knowledge and there is no translation or poor translation for the benefit of patients. So we have very good measures. We have very good instruments that we so just a few people, just a few clinicians, just a few neuropsychologists use in clinical context. So social cognition, that is the Cinderella of neuropsychology in neurocognitive disorder. So it needs to be more. We need to talk more on this. So I think that we would have these 2 days. We'll use. I think that we can use these 2 days for thinking about. So what's the first point, the first step, and then to start to open different venues for the direction of this consortium. I think that probably this is enough. So just 5 minutes. And I want to say, Alessandra, so to continue and talk about a little bit of this of the agenda of these 2 days.
Thank you very much, Chiara. Good morning, everyone. I have to say I'm a bit touched today. I don't know if it's because of the hormones due to the maternity, but anyway, go on. I'm not as good as Chiara with words. I'm better with numbers. So I would just like to share some numbers with you. The first one, if it looks. Okay, it's 14. And 14 is the number of countries for which we have representatives today in terms of panelists, experts, and methodologists. I think this is great. What it means is that we are building through our effort a new young community, and everyone here, let's say, find relevant the topic of this workshop. So the optimization of social cognition testing. And I'm sure that in these 2 days, we will, I hope, this is my hope, that in these 2 days, we will be able not only to describe the state of art through the amazing speakers that we have, but also move some steps, even small, towards an optimization of the clinical assessment of social cognition. So that's my hope, and I want to thank you, everybody. As I said, experts, panelists, methodologists that are here today with us, and also all the members of the consortium to share with us this aim. The second number is 245. And this actually is the number of kilometers that separate the two centers that organized these events. So the use here in Pavia, where you are actually, and the CIMEC in Rovereto. And when we, at the beginning in May, started to discuss about this initiative, in May 2022 actually, and even before, we started to discuss about this initiative. We were talking together and said, okay, should we do it? Can we do it? Yes. Let's do it. So I think it's amazing to be here today. It's a first achievement, and I hope this will be the first co-organized event of many. And I want just to share with you a practical information, since there is this cooperation. The event for the morning is available on the Zoom room led by Pavia, but also on the YouTube channel of the CIMEC Center, so the Center for Mind and Brain Sciences. And the last number that I have for you is not really a number, it's more an estimation, and it's higher than 50. This is the number, approximately, signature team, remember this number, of the meetings that we had since May 2022 to organize the initiative, to organize this workshop. And it's quite, for me, surprising as number. So here I want especially to thank the young members of the team, so Claudia Meli and Andrea Pensavolta. Without them, we couldn't make it. I don't hide the fact that we had to face some challenges, for sure. But if you follow our Twitter account, you know that we always did it with a good mood. Okay, So we have tried to prepare an interesting program with you that I'll, let's say, share with you briefly. The morning of today is an open event. So as you will see, we will have a first section focus on, let's say, the overview of social cognitive deficits in neurocognitive disorders. We have some speakers that are connected online due to, let's say, travel issues. Fiona Camphor, Jordi Matias Guyu, which studies here, myself, and Ian van der Stok. And then we will move, let's say, to the hot topic, so the harmonization of social cognitive assessment in neurocognitive disorder. And here we will have the presentation from Marina Boccardi, Simone Pomati, who will present some issue about cross-cultural assessment. And then we will have, let's say, a presentation of the signature initiative by Chiara, and we will see together the results of the clinical survey that you completed a few months ago by Andrea. Then in the afternoon, let's say the program is closed to the panelists. So we will have first a practical activity, and then we will move to the Delphi structure. And you will have a few hours to complete the first round of the Delphi. We will analyze the data, and then we will see tomorrow morning in order to discuss for which items we have an agreement, for which we have not an agreement, and run a second round of the Delphi. Of course, you see there's quite a time slot between the last, let's say, appointment of the afternoon, finishing at 4:40, and the social dinner. But in your shopper, you have a list of places where you can have nice aperitivo around the city. So enjoy the town, okay, while we wait for the dinner. I think we can start. That was all. Yeah. Maybe I can introduce me in time. Okay.
Okay, so I think that we can move to the first session, so we can ask Professor Papagno, Costanza Papagno, so Professor of Neurology and Clinical Director of the Center of Neurocognitive Rehabilitation, at the Center of Applying Brain Science, the CIME, to chair this session for the morning. So we will be there for technical issues. So me too, but the youngest will be there for the. So okay, and this is you. Okay. Okay. Yes. It's okay. Okay. With the name and yes. Yes. She's online, so just few minutes. I take advantage so to thank Fiona for being here. So it's so she knows that it's something that we really appreciate, and I'm afraid that she cannot be here, but I'm sure that will be other chances. So if we are
not ready, so a few minutes.
Okay, so thank you very much for inviting me to chair this session. And now I will introduce Fiona Camphor, who is an associate professor of psychology, I think neuropsychology, at the University of Sydney in Australia. And she will talk about social cognition in major neurocognitive disorders. Okay.
Hi, everyone. Hopefully you can hear me and see my slides.
Ah, ok, sto già condividendo lei. Ok, perfetto. Oh. Ok. Un attimo.
Se dobbiamo mettere...
L'audio attivo, ma non si sente.
Fiona, sorry, we can hear you. We can't.
You can hear me?
Just give us a few seconds. We try to solve the issue here.
Microfono aperto.
Ah, sì, il microfono aperto.
Forse non manca un...
You want to try now?
Yeah, can you hear me now?
Non ci sento.
Sorry for the inconvenience. Every time we try to say face every problem, but with technology, there is always an unexpected one.
Forse perché l'ha tirata via. No, dico, l'ha tirata via lei.
No, cioè. No, questo è giusto.
Sentono. We can hear her. So the other online can hear.
Okay.
I think online can hear me, right? It's just in the room.
No, Fiona, still we cannot hear you. Everyone online does. Okay, so it's a local problem. Problema qui della stanza perché.
Vediamo un po'.
Thank you, Michaela.
Maria Luisa manda il buon via.
Okay, now we can hear you.
Okay, fantastic.
Thank you very
And
much. Sorry.
And hopefully you can see my slides too.
Yes.
Yes, we can see them.
Okay, great. Let's get started. So yeah, I'm very, very sorry that I can't be there in person, but I'm very glad that I can be joining online. And it's an honor to be here today, but also I know there's a lot of people in the audience with a lot of experience and expertise that I'm sure they'll bring. So I thought since I was the first speaker today, I would start off with just framing sort of some of the definitions and what we're talking about. So when I was asked to talk about major neurocognitive disorders, of course, I went to the DSM, and they really talk about acquired disorders, which are primarily cognitive in nature and a decline from a previous level of functioning. And while often we use this synonymously with dementia, and today we're going to be predominantly focusing on dementia, it's just interesting to note that the DSM also includes a variety of other disorders such as traumatic brain injury, HIV, Huntington's, and so forth. And actually quite a lot of these other disorders are also characterized by social cognition impairment. I think there's a lot that we can learn from work that's been done in these other fields. But my area of expertise is certainly dementia, and that's what I'm going to be focusing on today. In the same way, I think it's useful to think about what we're talking about in terms of social cognition. And when we think about it from an experimental neuropsychology point of view, we look at these range of different behaviors that support social interactions. And they include things like emotion recognition and understanding of social norms, but also things like interoception, body language, and expression, and so forth. And while the DSM focuses on emotion recognition and mentalizing, there's really yet to be a sort of overarching theoretical framework that determines what the subdomains of social cognition are. And I think that really comes through in some of the complexities when we're thinking about what tests we're going to select and how we're going to approach assessment in these disorders. But to date, most of the evidence is on emotion recognition and mentalizing. And again, that's what I'm going to be focusing on today. So why is it important to assess social cognition? Well, obviously, one of the major reasons when we think about it is in terms of diagnosis. And in the case of neurocognitive disorders, it might be answering the question to start off with, is this a neurocognitive disorder or not? So does this person have a dementia syndrome, or is this healthy aging? It's also very relevant in terms of differential diagnosis. So for example, differentiating between syndromes like frontotemporal dementia and Alzheimer's disease. And again, I think that's where a lot of the work that we're going to be talking about over the next couple of days is going to focus, and certainly where a lot of the research is. But from a clinical perspective, it's important to assess social cognition just not from these diagnostic perspectives, but also to think about how it might be useful in terms of prognosis. So we know for clinicians that one of the main questions that families will ask is, what's going to happen? What can I expect? And at the moment, we're very bad at predicting those individual trajectories of clinical progression. And again, I think there's an opportunity for social cognition in terms of helping us understand those individualized patterns of disease progression. And the other aspect that's really critical is thinking about management and treatment plans. So there's quite a lot of evidence now to show that social cognition is a significant predictor of care burden for people with dementia. And it is also a significant influence on someone's quality of life and their independence in terms of everyday functioning. But there's very little in terms of social cognition interventions. That being said, there is a lot of development in other populations, for example, brain injury and autism, that may be relevant when we're thinking about how we can assist these people that we're working with. So again, when we're thinking about assessing social cognition, depending on the question that we're asking, we might be selecting different tests. So today I'm going to focus predominantly on the diagnostic side of things, and in particular focus in on behavioural variant frontotemporal dementia. And I'm sure for all of you in the audience, you're aware that social cognition is particularly relevant in terms of this particular syndrome. And when we think about why, there's really this paradox of behavioural variant FTD. So when we look at the current diagnostic criteria, social cognition isn't currently included, but the diagnostic criteria focus on executive dysfunction in the context of relatively preserved episodic memory and visuospatial ability. One of the challenges, however, is that there's been quite a lot of work examining this profile of neuropsychological functioning in behavioural variant FTD. And what we see is that how people present isn't quite as clear-cut as what the diagnostic criteria propose. So firstly, there's been quite a lot of work looking at episodic memory and behavioural variant frontotemporal dementia. And what we can see is that for people with behavioural variant FTD, which is the PR group on this chart, they can actually perform as impaired as people with Alzheimer's disease. So actually this relative preservation of episodic memory doesn't really hold true when you look at the actual clinical presentation of this group. And similarly, when you look at something like visuospatial ability, actually people can perform quite poorly on something like a Ray complex figure because of their poor executive dysfunction and how they go about and approach the task. So for example, this individual here has taken this very piecemeal approach, which has led to a very disorganized Ray figure. So again, you might see that visuospatial ability isn't necessarily preserved on testing. The other issue that we see clinically is that people with BVFTD can actually perform within normal limits. So again, if you look at the example of this episodic memory performance, actually there's people who are performing similarly. And I think it's very helpful to look back at some of the earlier comments by Marcel Mesulem in terms of people with frontal lobe damage, that people, even with major behavioural difficulties, can behave impeccably in the office, and that the office setting may introduce sufficient external structure to suppress some of these behavioural tendencies. So there is this issue where people with behavioural variant FTD can perform normally on a range of neuropsych tests. The other sort of issue is this diagnostic complexity, where we see within BVFTD that there's a variety of different presentations, which can be challenging to differentiate, but also the ability to differentiate between dementia and primary psychiatric disorders. So for example, is someone presenting with depression or with behavioural variant FTD? And that's really led us down this path of thinking about, can social cognition help? So there's been quite a number of early studies using classic tasks like the Ekman faces. And even as early as 1999, it was shown that there were clear deficits in people with FTD compared to Alzheimer's disease in their ability to recognise facial emotions and also their ability to understand faux pas. So this example, again, from the early 2000s, showed that people with BVFTD are significantly more impaired in recognising faux pas compared to people with Alzheimer's disease. And there was sort of varying performance on other theory of mind tasks. Since then, the area has really been rapidly growing. So we've seen a rapid increase in tests in studies looking at social cognition in FTD over the last 20 years and in social cognition more broadly. So in 2022, there were over 2,000 papers published on social cognition. And there's been a number of meta-analyses now that have been looking at performance in people with FTD, and I'm just going to focus on those. So firstly, when we look at facial emotion recognition in people with BVFTD, there's quite clear evidence now to date to show that people with BVFTD are significantly impaired in their ability to recognise emotions, both in comparison to healthy controls and people with Alzheimer's disease. So that's pointing to the utility in terms of diagnosis and also differential diagnosis. And when we look at performance on theory of mind tasks, we also see this impairment across a range of theory of mind tasks. But here we start to see some heterogeneity in terms of the discriminatory ability of these tests. So the effect sizes of tasks looking at faux pas detection and also sarcasm detection seem to be considerably more sensitive at discriminating between behavioural variant FTD and Alzheimer's disease than other tasks like false belief tasks. Interestingly, when we think about FTD, it doesn't seem to be unique to behavioural variant FTD. This meta-analysis looked at BVFTD and compared its performance in people with semantic dementia and progressive non-fluent aphasia. And interestingly, they found that general cognition was impaired to almost a similar extent as social cognition. And interestingly, they also showed that the degree of impairment in social cognition was similar across the FTD subtypes. So it seems to be something that is more affected in the FTD syndromes than in Alzheimer's disease syndromes. Looking at the impact of cognition on performance, we can see that the ability to recognise emotions and to complete these theory of mind tasks depends on a variety of perceptual skills. But as is becoming clear, social cognition impairment is now well established in semantic dementia, and there is this variable performance in progressive non-fluent aphasia. But from a clinical perspective, it's really important to select less verbally demanding tests because we know that language impairment can impact on performance. And when you use these types of tests that are less verbally demanding, it's clear that these social cognition impairments are evident in these groups. What about the impact of cognition on performance in other cognitive domains? Well, we can see in people with Alzheimer's disease that they're not impaired on tests of sarcasm detection after controlling for general cognition, and that tasks like the tacit, which include both non-social and social conditions, can be really helpful to differentiate the extent that cognition might be influencing performance. We also see that theory of mind differences between behavioural variant FTD and Alzheimer's disease remain significant even after controlling for cognition, like performance on the MMSE, as well as disease duration and CDR. So again, suggesting that these changes are really robust. But as I said, it can be really useful to include these non-social control conditions to identify the extent that cognitive performance may be affecting the performance on these social cognition tests. In terms of neurobiological validity, there's been a number of studies now that have been looking at the neural correlates of performance on a range of social cognition tests. And I'm not going to go into detail just because of the time limits today. But when we think about the regions of the social brain, you can see that they quite clearly overlap with the regions of atrophy in these neurocognitive disorders. And a meta-analysis that was done by Adolfi et al. A few years ago looked at the regions that were activated during social cognition tests, emotion tests, and interoception tests. And they found that it was really these frontoinsular regions that were particularly involved, and that if you looked at individuals with damage to this particular frontoinsular region, they performed poorly across these range of social cognition tests. So there is considerable evidence showing that social cognition tests do have good neurobiological validity. But despite this, we know that these tests are rarely assessed in clinical practice, and that psychologists report very low self-confidence in their ability to assess social cognition and also their ability to treat or manage these social cognition impairments. So why might this be the case? There's a number of studies now that have asked clinicians about some of these barriers. And again, I think we'll be discussing this more today. But there's a real lack of normative data available. There's a lack of psychometrically sound tests. There's a lack of knowledge and training for clinicians in terms of how to assess these domains. There's a lack of time. Often the tests that have been developed experimentally take far too long than what's appropriate in a clinical setting. And there's also this question about how to account for cognitive impairment. The other important aspect in terms of challenges for implementation is how these tests can translate internationally. So we know that most common tests of social cognition have been developed in Western populations. And although there's growing evidence to suggest that things like emotion recognition and emotional expression may be relatively universal, there's also considerable evidence to show that particularly theory of mind tasks might be influenced by cultural variation. So for example, this study found that differences in countries accounted for more than 25% of variation on faux pas test performance. So we've been doing a review to look at the availability of tests across different cultures. And what we've found in terms of emotion perception is that really, as I'm sure is not surprising to the people in the audience, that most of the studies have been collected in Western countries, and that there's an overwhelming focus on tests that have been developed in English and also using Caucasian stimuli. And we found a very similar pattern in terms of theory of mind or mentalizing tests, where again, the predominant language is in English, and there's numerous regions where there aren't normative or validated studies available. So to summarize, I think we really need to think about what is the goal when we're assessing social cognition. It's unlikely that a single individual test is going to be sufficient, but there's really good evidence now to show that social cognition assessment can be really helpful in improving the differential diagnosis and diagnosis of frontotemporal dementia and differentiating it from Alzheimer's disease. It can be useful in terms of tracking progression, and that there's potentially a role for social cognition in things like drug trials and how we can detect change. And also, even though treatment and management of social cognition impairment has been relatively underexplored, it's very important in terms of clinical practice. So we know that facial emotion recognition is relatively preserved across cultures. It has somewhat lower cognitive demands, and there's consistency across different tests. Whereas mentalizing and theory of mind, there's multiple tests that have been developed with varying stimuli and responses. There's more cultural variation and varying cognitive demands. And we still have few limited head-to-head comparisons, but it does seem like faux pas tests and sarcasm detection tests may be better at discriminating these groups. So in terms of considerations for test selection, we really need to think about how timely they are in terms of the amount of time that they take to administer, how we can account for cognitive impairment, how we can minimize language demands, what the validity is across cultures and languages, what their psychometric properties are, and also thinking about performance-based versus informant report, because often we rely on informants, but they may not be the most accurate or available in terms of determining the presence of social cognition impairments. And in terms of moving forward, we need to think about how we can put the social back into social cognition, how we can better develop normative data, and really thinking about a theoretical framework for understanding and framing social cognition. So thank you very much for your time, and I'm looking forward to the rest of the talks.
Thank you very much for your very clear presentation. Are there questions? Okay.
So thanks, Fiona, for the presentation. Thank you. First of all, it's a consideration. So social cognition deficits not only relevant for the behavioral environment, also for other syndromes, even if they are within the spectrum of the frontotemporal lobar degeneration. But this is, I think, a very important. Doesn't work. Vabbè, I come here. So low batteries. So no, I think that so it's a very important consideration, the fact that social cognition in major neurocognitive disorder is relevant not only for the behavioral variants but also for other cognitive syndromes, and this is I think one important thing. So another is I have a question. So in your review, so are there evidence from experimental neuropsychology in the use of pragmatics, so social communication tests? So because this is an issue, or this could be an important so element. Also in the discussion, so putting, as you mentioned at the end of the presentation, so putting the social in the context, in the real life scenario. So social communication aspect of neuropsychology is very important. So what's your opinion?
Yeah, thank you. So pragmatics is obviously a very large field, and there's been some efforts to develop work. In some ways, the awareness of social inference test does tap into pragmatics to a degree, because it's looking at those social interactions and social communication, looking at how people can detect things like sarcasm. And that does seem to be one of the things that differentiate behavioral variant FTD from Alzheimer's disease quite well. I think one of the issues with pragmatics is thinking about some of the primary progressive aphasias that we do also see in the frontotemporal dementias that obviously are going to perform poorly because of their language impairments and not necessarily because of their social cognition impairments. So typically we try and avoid very verbally demanding tests so that they are suitable across the range of disorders rather than developing specific tests, but there is, of course, benefits in terms of pragmatics. And I think the question of putting social into social cognition is a really important one. So we've been doing it in some aspects, looking at physiological responses so that you're not sort of getting an overt response when people are in social situations. And the other thing that we've been doing is looking at observing people's behavior. So we've looked at interactions where people have been videoed speaking with their neurologist and looked at nonverbal behaviors. And we've found things like behavioral variant FTD patients tend to stare a lot more, whereas people with semantic dementia tend to use more gestures. So there do seem to be ways that you can identify these differences in social behavior through more observational means where people are actually interacting. And I think that can help bridge this divide between looking at, I guess, static facial expressions on a computer versus what the demands that people are going to face in these more everyday social interactions.
Just to reply, so I totally agree with you. I think that opens also some ethical issues about privacy issues, and so I think that it will need much more effort. For, in my opinion, I think that it will change the way the services, the neuropsychology services, the way the professional works, also in the way the patients thinks about being cared and be diagnosed by it's something really important, at least in our context, at least the way we in Italy work. So, but thanks.
Yeah, I guess just briefly, that is important to some extent in terms of the ethical requirements, but also I think as neuropsychologists and clinicians more broadly, we often observe people's behaviours and use that as sort of qualitative judgment. So even if you're not sort of formally measuring people's behaviours, observing their nonverbal behaviours may be very useful in terms of picking up some of these changes. But yeah, of course, we need to be careful in terms of the ethics around it.
Alessandra.
Yeah, Fiona, hi, Alessandra. Thank you very much for the presentation. I have a question. The topic is mainly the same, and you partially already answered to that, but I was interested in a specific facet. So you mentioned that there is this mismatch between social behavior and performance, the social cognition task. and you said, okay, we are developing new tests, new measures to assess real life interactions. I was wondering if you think that also there can be a role for families and caregivers in helping us in developing more efficient measures. What do you think about that?
Yeah, so definitely in populations like behavioural variant FTD, where there's limited insight, obviously the family and carers are really integral to the assessment. And I don't think there's necessarily a huge mismatch between social cognition and everyday social behaviour, but it is something that's been relatively underexplored. So I have a student at the moment who's actually looking more in detail at social functioning and asking family members about things like you know, how good their interactions are with the person, how often do they visit family and friends, how, you know, what's the quality of their social interactions in everyday life, and then seeing how closely that's predicted by social cognition, because it's surprisingly something that is sort of assumed in the literature, but we haven't looked at in a lot of detail. In terms of developing new tests with families and carers, I think there's also work to look at these more ecological measurements, and absolutely I think understanding how people are functioning in everyday life is critical. So hopefully some of these tests that we can use in the clinic is giving us a window and an insight into, I guess, those everyday activities, but working with families is essential.
Any other questions? Just one quick question I would like to ask you, but so now if there is this problem with language, which test would you suggest now as possible for people with semantic dementia? Because I cannot think of a test not involving in some way verbal abilities.
So we use facial emotion perception tests. You can use a sort of classic labeling test and just check with the person with semantic dementia that they still understand, you know, what anger means and what disgust means. But the other way that works quite well is to do a matching task. So either to show two facial expressions and ask them whether they're the same or different, or to show them three faces and get them to match, you know, the angry face with another angry face. So there are ways to assess at least emotion perception.
There are already normative tests, normative norms, standardization for this kind of test.
Yes, that's a very good point. So yeah, so those tests are ones that have been developed experimentally, and we're still collecting normative data, but absolutely that's, I guess, where we get this gap between experimental neuropsychology and the translation is the
Yes, I imagine that these were tests, but I was wondering if we have, if there are somewhere norms for perception, discrimination, etc.
Yeah.
Thank you. Now, thank you very much for your presentation. And
thank you.
Next speaker is Jordi or Jordi. Jordi. I know that Jota is Jordi Matias, who is a clinical researcher at the Universidad Complutense de Madrid. And he will talk about social cognition, but in minor neurocognitive disorders. Thank you very much. Over there.
Thank you for the presentation, and thank you so much for the invitation. It's my pleasure to be here. Thank you, Alexandra, Chiara, and all the signature team. The title of my talk is about social cognition in minor neurocognitive disorders. This is the outline of the talk. We will first review the relevance of social cognition in the diagnostic criteria of minor neurocognitive disorders and other related disorders. We will then review some studies addressing the existence of social cognitive deficits in the prodromal stages of frontotemporal dementia, Alzheimer's disease, and other neurodegenerative disorders. We will then review briefly about the assessments, the clinical validity, the cross-cultural availability, and the neurocognitive, and at the end we will make some conclusions. As you know, in the last version of the DSM, social cognition has been recognized as one of the cognitive domains. This is important because according to this criteria, it's mandatory to assess social cognition to diagnose, to reliably diagnose minor cognitive disorders in the clinical and research practice. It's important that social cognition is defined, may be defined as a concern of the individual by an informant or the clinician as a change, and preferably documented by a standardized neuropsychological testing. So this is a call to improve the neuropsychological test in the context of minor cognitive disorder. A parallel concept is the emergence of this mild behavioral impairment, similar to mild cognitive impairment, but more focused on the behavior. And in this concept, also social inappropriateness, the lack of empathy, loss of insight, and interpersonal relationships, and other aspects of social functioning are emphasized. So it's important to, it's increasingly important social cognition in the definition of these prodromal stages of the neurodegenerative disorders. Similarly, in the last proposed research criteria for the prodromal behavioral variant of frontotemporal dementia published last year, social cognition was recognized as one of the criteria to diagnose and to detect this clinical this disorder. However, according to the authors, this poor social cognition criteria should only be applied if there is a meaningful reduced performance on a validated measure of social cognition. And the authors to perform this develop this criteria use a subjective questionnaire, the revised self-monitoring scale, but they suggest that other aspects of social cognition may be useful also to complete this criteria. And in fact, they strongly recommend that future studies should consider other cognitive tools to improve this criteria. So it's clear, according to these studies and these criteria from the DSM, the concept of mild behavioral impairment, and the last criteria for prodromal stages of frontotemporal dementia, that in the context of minor cognitive impairment, assessing social cognition is important. In fact, in the behavioral variant, social cognition deficits, as you know, are early and very prominent features. Social cognitive deficits are considered a hallmark of the clinical syndrome, and this makes sense because they occur before other cognitive deficits, because they are more linked to some regions such as the orbitofrontal and medial frontal cortex and these regions are impaired before than the dorsolateral prefrontal cortex, which is more linked to executive function. However, the knowledge about social cognitive deficit in frontotemporal dementia is relatively recent, and for this reason, this was not included in the current criteria, as I mentioned in the previous talk by Dr. How early are social cognitive deficits in frontotemporal dementia? In this case, the studies performed using a genetic form of frontotemporal dementia represent a good model to study the moment in which social cognitive deficits may be detected. And according to this study, social cognitive deficits in frontotemporal degeneration are already present since the prodromal stages of the disease. And even in some mutations, for instance, in the C9 expansion, these deficits could also be present in the late pre-symptomatic stage. So, at least in frontotemporal degeneration, these deficits appear early and are prominent since the stage of neurocognitive impairment. Regarding Alzheimer's disease, there are a lot of studies studying in the context of myocognitive impairment, in amnestic myocognitive impairment, and according to this meta-analysis, this social cognitive deficit is also present from this neurocognitive impairment, generally with medium effect size. However, it's true that in Alzheimer's disease, there is certain variability and inconsistency of the result. There are differences in heterogeneity in methodologies, in design, in the complexity of the tasks applied. Recent studies have shown impairments in emotion perception and theory of mind, which could also be present since the MCI or autonomous stage of Alzheimer's disease. Even some studies have correlated social cognitive deficits with altered behavior or everyday function. So it's not also important for diagnosis, it's also important in clinical, for the family and in clinical diagnosis and clinical management. But however, most of the studies lack confirmation by biomarkers, and the clinical diagnosis of MCI was clinical and not supported by biomarkers such as CSF or by imaging, and include generally relatively small samples. This is interesting to look at biomarkers because mainly in the concept of mild cognitive impairment not supported by biomarkers would disentangle some subgroups. For instance, this is an interesting paper by Dr. Dodik suggesting that according to the profile of PET imaging, of FDG PET imaging, there could be some differences in social cognition, deficits, and this could be suggestive of other comorbidities or other pathologies like late or other pathologies in the context of amnestic myocognitive. Another important cause of cognitive impairment is, of course, dementia with Lewy bodies. Here, there are very few studies in the prodromal stages. This is probably the most important, in my opinion, in which 37 patients with prodromal dementia with Lewy bodies were examined, and emotional recognition was not affected, but there are some difficulties in theory of mind. However, it's unclear in this thing if there is a specific deficit of social cognition or this is in association with another cognitive deficit more prominent in this disorder, and that impairs social cognition directly or indirectly, limiting the usefulness of the task, such as executive deficits or visual perception skills. But this would be important to disentangle these potential differences in social cognition, because another disorder, another atypical Parkinsonism, such as progressive supranuclear palsy, in this study, they have found more prominent deficits similar to behavioral variants of the dementia and with a similar neurobiological underpinnings. So this revised reviewed studies confirms that socio-cognitive deficits are present since the programmal stages of the different disorders, but probably in different magnitude and in different associations to other cognitive functions. Regarding the assessment and the clinical validity of these cognitive, social cognitive tests for the diagnosis of Alzheimer's disease, for the diagnosis of febrile frontotemporal dementia, or for the differential diagnosis between them, there are generally several studies published suggesting that these tools may be useful for differential diagnosis, although it's true that many studies are not specifically focused on prodromal stages and include patients that are minor cognitive impairment stage or also major cognitive stages. However, probably the combination of some social cognitive tests could be used for diagnosis, as shown in these papers, with 5 areas under the curve for the differential diagnosis between frontotemporal dementia and Alzheimer's disease. But it's important to consider also other aspects of the cognitive assessment. So social cognitive, as in other cognitive domains, should be interpreted in the context of the examination because there are other cognitive functions impacting in the assessment of social cognition. In this regard, it's interesting this paper that are combining social cognitive measures and a general and global cognitive measure obtains really high areas under the curve to discriminate between behavioral variants of temporal dementia and controls, Alzheimer's disease and controls, even Parkinson's disease and controls, and also between these disorders. These tools are probably very useful because when comparing to other traditional neuropsychological tests, the area under the curve, in this case of the reading in the mind eyes test, was equivalent to semantic and referential fluency and superior than a traditional executive test in the context of the temporal dementia. But probably it's not also important to look at the score of the test, but also to some qualitative aspects. And this is an interesting study searching for potential differences in qualitative aspects across several disorders. Another important issue nowadays is the cross-cultural availability of these tools. As you know, tests with favorable cross-cultural properties are more necessary due to the increasing ethnic and cultural diversity, and also to make multi-center studies with more potential for generalization of the results. Socialcognition has been run as one of the most challenging domains to assess in a Delphi consensus setting for cross-cultural tests. But there are some tests that have been adapted to several languages and cultures, and CNC, and other tests probably do not require specific adaptation, although cross-cultural applicability should also always be confirmed. Regarding the neurocognitive, we have good neuroimaging studies correlating each specific task with the brain regions associated with social cognition. In this regard, there are studies using the mimicking behavioral variant frontotemporal dementia, the story-based empathy task in behavioral variant frontotemporal dementia, the passive, also in Alzheimer's disease, also another task in Alzheimer's disease, and generally these studies support the validity of this task to examine the function of several regions specifically involved in social cognition. So, to conclude, social cognition is impaired in several neurodegenerative disorders since early stage, the stages of minor cognitive disorder. Social cognition dysfunction is a cognitive hallmark in behavioral and frontotemporal dementia, and the assessment of social cognition improves the early and accurate diagnosis of behavioral and frontotemporal dementia. However, social cognition is also impaired in different degrees in other forms of frontotemporal degeneration, like American's aphasia, in Alzheimer's disease, in dementia with Lewy bodies, and other disorders. There are potential differences in social cognition of subdomains according to each disorder and stage, and this is an interesting topic to be addressed. For instance, the differences between theory of the cognitive theory of mind versus affective cognitive theory of mind, probably due to the different cognitive processes involved and the different neural underpinnings. There are several tests available to evaluate social cognition, which have shown favorable diagnostic properties and neurobiological validity, sometimes in isolation, but many times in combination with other tests. And this is important as in other cognitive functions, neither is totally specific, and findings from neuropsychological examination should be interpreted in the context of clinical data of other cognitive status, of behavior, daily activities, etc. However, we have several areas of improvement. For instance, we need more studies supported by biomarkers. We need studies directly comparing instruments in order to find the most optimized strategy to improve the assessment of social cognition and the neuropsychological diagnosis. We also need studies supporting the clinical relevance of the measurement of social cognition. For instance, evaluating the implications in daily life or the association with more prominent behavioral symptoms. And it's also important to consider the context of the examination. Most of the studies in this field have been performed in highly specialized memory clinics, and it's important that if these are instruments to be used to screen, to detect, to examine mild stages of neurodegenerative disorders, it's also important to apply and to validate in non-specialized settings such as primary care or general neurology care or clinical scenarios. Thank you so much.
Thank you for your talk, and we have time for one question. Sorry? Online?
Yeah.
Yes. I have there are two questions. I would like to ask whether we could measure the premorbid levels of social cognition, especially in the so-called as minor behavioral impairment. Marianna Zatali.
Yes, this is a very important question. This is also an issue in general in neuropsychological assessment, in which is difficult to address the previous functioning, also in memory or in executive function, etc. I think that in this case, we should, if we have no previous examination, we should look at subjective questionnaires from the family. And also probably using normative data to evaluate the performance according to the expected performance according to age, culture, education, etc. But this is a very interesting issue.
There is a second question. If you can,
It's not a question.
it's not a question. To read it.
Yes,
not a question.
Dr. Bertux say that just a quick thought, not a question. We think about family and careers to help design tasks, yes, but programmable patients can also help to really understand impairments as well as compensation mechanisms, and could provide very relevant ideas to design tests as well. I think some of them suffer from the fact that we are not listening them enough. We tend to give career more space in conference, etc. than patients. So it's a win-win context.
Thank you. Now I'd like to introduce Alessandra Dodic, who is Assistant Professor of Psychology at the Center for Mind Brain Science at the University of Trento. and she will talk about accuracy of social cognition measures in neurocognitive disorders.
Thank you very much, and good morning again. So after this overview on major and minor cognitive disorder, here we are, let's say, we thought to focus more on the accuracy of social cognition measures in let's say the diagnostic framework of neurocognitive disorders, knowing the fact that, as already Jody said and Fiona said, it's not a test that makes the diagnosis, but it can help in the process. So, of course, when we talk about social cognition and neurocognitive disorder, the first thing that we have in mind, as we already seen, is the behavioral and temporal dementia, used also as model to study the social brain. And an interesting thing already mentioned is the fact that when we see the criteria proposed in 2011, we actually, let's say, have in the list the fact that this patient can have inappropriate social behavior or social disinhibition. But if we have a look, if we have a look at the neuropsychological criterion, here we have a significant deficit in executive function with a relative sparing of memory and visual spatial skills, but no specific criteria on, say, social cognition deficits or deficits of social cognitive tasks. And actually, in the criteria is also reported the fact that, yes, tests of social cognition can provide objective markers of cognitive dysfunctions. However, since these tests are not widespread in the clinical practice, they were not incorporated in the clinical criteria. What happened after 2 years, so in 2013, with the DSM-5, something changed. So here you see the list of neurocognitive domains that should be used in a certain way to also guide the clinical diagnosis in neurocognitive disorders, and together with, let's say, the well-known ones, so learning and memory, executive function, perceptual motor function, competence attention, we also have social cognition. So the DSM underlined the importance of evaluating social cognition in these patients. So in the next 10, 12 minutes, I'll try to answer these two questions, since here we are moving in the clinical context. Do we have tools and measures to assess social cognition deficits in the clinical setting? And what is the clinical validity of these social measures in the diagnostic framework of neurocognitive disorders? Good questions. So, since the, let's say, the publication of the criteria, many laboratories developed or adapted tests for the evaluation of social cognitive deficits in these patients, following in a certain way, let's say, different steps. And here I will show you as an example what we have done with the story-based empathy task. So first of all, of course, you have the development of the test and also the, let's say, the definition of the normative data. You, let's say, want also to be sure or have proof of the fact that in order to perform well in that test, the integrity of the regions that belong to the social brain is there. And another step that you can do is to assess the clinical validity. So evaluate if the test is able to distinguish your population of interest from healthy controls or other populations. So what we do with the story-based empathy task, which is a test evaluating emotion and intention attribution compared to a control cognition, was first to provide normative data and to evaluate the underlying neural correlates. And as you can see here, what we found was that the performance at the subtask of emotion attribution was significantly correlated to the integrity of, let's say, both functional and structural, let's say, it was correlated to the integrity of regions that belong to the social brains in terms of structure and function. And recently, what we have done together with Ian van Stock was also to evaluate the transdiagnostic overlap in these brain correlates, we analyzed the regions found by another colleague, Fabio Campanella, who evaluated the deficits at the story-based empathy task in patients with brain tumor. And we found a nice overlap in the regions required to perform the emotional attribution subtask in both patients with tumors and patients with the behavioral bias from temporal dementia. However, as I was mentioning, another important point can be the clinical validity. So is this test able to tell us something in terms of diagnosis? And here, and here you see just a table, let's say, summarizing the diagnostic accuracy of both the emotional attribution subtask and the Ekman 60 phases test in distinguishing BVFTD from healthy controls and also BVFTD from Alzheimer's disease. So it's true that in these years we have many tests, not only absolutely story-based empathy tests, but many others that help us in characterizing the social cognition deficits in these patients. And this is something, a picture that you have already seen in the presentation of Fiona Camphor. So in the last few years, we had more than 2,000 publications evaluating social cognition dysfunctions in these patients. However, when we try to, let's say, evaluate and or review, let's say, the clinical validity of these tests in the characterization of these patients, we found a different picture. So we focus only on tasks administered to patients, and starting from 600, around 600 papers, we only found 14 papers reporting measures of accuracy, so diagnostic accuracy or sensitivity and specificity. And we will have a quick look to the results. But first, here table, we don't need to read it in detail, but just to give you an idea of the fact that now we have some tests for which we have clinical validity in these populations. Two thoughts. The first one is the majority of these tests both consider, let's say, as a single test, so standalone test, or composite batteries are focused on emotion recognition and theory of mind. Only a few of them are, let's say, focused on other aspects such as social knowledge or social reasoning. And the nice thing is the fact the majority of them has also neurobiological validation. So we know that actually to perform well to this task, you have to have a maintained social brain, even if different areas are involved in different tests. So here we have a look at the results of the systematic review. So here you see the studies that evaluate the diagnostic accuracy of social cognition tasks in the comparison between, comparing BVFTD from healthy control. What we see is a nice accuracy around the ranges from 85% to 97%. But still we have some problems. The majority of these studies are on small patient groups, and the characterization of these patients is quite heterogeneous in terms of, let's say, diagnosis using or not biomarkers, and also different biomarkers, as you can see. If we move on the other hand on the let's say diagnostic accuracy of this test in dividing FTD from patients with Alzheimer's dementia, here the results are a bit, say, less reliable in the sense that the accuracy range is higher from 70% to 94%. So we have a wider variability in the results. But once again, we have the same problem. So studies with small sample size, heterogeneity in the characterization of patients. And once again, as I mentioned before, the majority of them was focused on emotion recognition or theory of mind assessment. So unfortunately, or luckily, there is still a lot to do. If, as an exercise, we apply the search string that we use for the review to the mild neurocognitive disorder, so just modifying, let's say, the search string, we have only 29 results, and actually 3 are eligible. The first one, as you can see, is focused on actually the ability of an emotional process recognition task in distinguishing patients with Alzheimer's disease and amnestic mild cognitive impairment from control, showing, say, a moderate sensitivity and specificity. While the other 2 papers were focused instead on mild behavioral impairment. And what we found, it is actually quite interesting and promising. The first one found that a combined presence of different aspects, so isolated frontal apathy, reduction in executive function, reduction in fear of mind, and preserved memory, show a good, actually 100% of specificity in predict the conversion of these subjects to frontotemporal dementia. And say in the new research criteria proposed for the prodromal behavioral variant frontotemporal dementia, you see that both the let's say the performance at the social norms and also the score at the revised version of the self-monitoring scale show good specificity in discriminating prodromal FTD from healthy control. So if we want to answer or try to answer to the 2 questions, so the first one, do we have tools to assess social cognition deficits in clinical settings? It's true that we have an increasing availability of tests for clinical use, which sets different subcomponents of social cognition, mainly focused on emotion recognition and theory of mind. However, you have already seen a lot of however in Fiona's presentation and also in Jordi's presentation. So I just focus on 2 aspects. The first one is that we have many more measures and tasks, but these are unfortunately usually limited to the research context. So you see here, social cognition, of course, is an umbrella term, which had inside several subcomponents. So possibly evaluating only, probably evaluating only emotional recognition and theory of mind, we are missing relevant facets. And linked to this, what should we do about, let's say, alteration in social behavior and alteration in social cognitive skills as, let's say, neuropsychologists in clinical settings? Should we assess both separately with different measures or not? And this is a question that came into my mind reading also the, let's say, the description in the DSM-5 of the symptoms or observation when describing social cognition alteration and the example of assessment. And this point has been already raised by Fiona during her presentation, so I think it's something on which we should think about. If we move to the second question, so what is the clinical validity of social cognition measures in the diagnostic framework of neurocognitive disorders? It seems that now we have tools that show a good clinical validity in the clinical diagnosis of VVFTD when comparing this group with healthy controls. The results of the clinical validity when taking into consideration VVFTD patient and Alzheimer's disease is more under discussed due to say a lot of open issues about also the heterogeneity of the performance that we can have in patients with Alzheimer's disease. And even here we have some however. The first point is that if we instead have a look at the availability of evidence about the diagnostic accuracy in mild neurocognitive disorders, we really have limited information and evidence. And the hope is that with the new research criteria, we will have also a boost of studies on this topic. And the other relevant point, as already underlined. What about the other syndromes within the frontotemporal spectrum and the neurocognitive domains? As already mentioned by Fiona, for example, if we take into consideration primary progressive aphasia, we have evidence of the fact that this patient can have also early alteration in social cognition. So the usefulness of social cognitive tasks in the differential diagnosis between these syndromes is still something that we have to, to study in depth. So, of course, there are many things to do. Through the signature consortium and the initiative, we hope to help finding out and have some responses. My take-home message, since here we are in Italy, we say Rome wasn't built in a day, but we are in Pavia. So let's say the Certosa di Pavia was not built in a day, and nor is the assessment of social cognition, but let's add some bricks together. So with a positive mood.
Thank you, Alessandra. Are there any questions? Question, Alessandra. Why do you think there is this resistance or using social cognition test in the clinical practice?
Well, in general term, I remember one of my mentors once said, when there is something new, the first reaction is, no, it's completely useless. Then they think about that, it's introduced, and then the final is, well, obviously we must do it. So maybe it's part of the process. It's something new. It's true that it's something complex to assess and to reliably, evaluate it. There's, as we have seen, also the influence of other social cognitive domains by performing this task. So I think it's something difficult to be isolated. The other possible reason, maybe it's an historical one. So when we think about dementia, general population think about Alzheimer's dementia, where you have relevant deficits in terms of memory, executive dysfunction that significantly affect, let's say, daily living. And maybe, that's my idea, social cognitive changes is not something that appears so much at the beginning.
Okay.
No, but my question is that in your presentation, so there are more questions than yesterday, Mariana at this moment put on her. Yesterday we had an event, an Italian event. So and we started with the representative of the family association about the social changes, but with the law experts. So what we think what is trial to have which kind of problem legal issues. So together with the who we are now. And at the end of the session on Stefano Zago, so he put in place a focus group on the discussion about which are the most important issues for the family, the caregivers. So putting in a focus group this. So I think that we should think about the fact that also to answer to the question. So it's important to investigate in also qualitatively also or quantitatively the social behavior changes. Okay, but it's okay. Okay, so the social behavior, the social cognition skills. So I think that the patients and the caregivers should have the opportunity to tell us which is the also their perspective in this sense. And the focus group process could be the best way also to put them voice of them into.
Yeah, I can do that.
Thank you. It's Marianna Zappali. Quick question.
Congratulations to this wonderful presentation. It's a really very interesting point. I would like to ask about the ecological validity of this kind of tests. How we could say that tests measuring social cognition are closely related to what a person does in daily life? How is the social cognition levels in daily life, in personal relationships by means of minor cognitive decline, at least, which is more difficult to distinguish. And the second issue is, I wonder whether we could detect social emotion differences in daily life using artificial intelligence or small devices to detect the differences in emotions, using, for example, smartwatches, specific mirrors to detect faces differences and so on. Thank you.
Okay, I'll try to answer to both questions together. I think this is a good point. So can we, are we sure that what we are measuring during our neuropsychological assessment when using a social cognition task is a representation of what actually the patient does in a real life scenario? So this is something that Fiona explained very well, I think. So it's important for sure to have, let's say, an agreement between these two aspects. Sometimes it can be difficult because these can be patients who, let's say, perform well at social cognitive tasks, but have misbehavior in their life. So one thought that I have while you were, let's say, asking the question is that to the, let's say, the framework that I shown, having test development, neurocorrelates, and clinical validity, we should probably add a will about ecological validity. So does it actually represent the real life situation? And I think that in this sense, smartwatch, new, let's say, digital solution can probably help in this, evaluating, let's say, the behavior and also the reaction of the subjects in a real life environment.
Okay, thank you. And now I will introduce Jan van den Stok, Associate Professor of Neuroscience at the University of Leuven in Belgium, who is talking about the experience of social cognitive group of NIS FTD. Okay, thank you very much.
Hello, good morning, everyone. I'm also very honored to be invited by the consortium to give a bit of information about the work we have been doing in the NIC-FTD. I think I'm also very sorry that I have to do this online because especially regarding social cognition, it's as a social cognition researchers, it's evident for us what the disadvantages are of all this online meetings. But still, I think this was the best or the second best thing we could arrange. Okay, so let me maybe start a bit by by explaining what the NIC-FTD is. So it stands for the Neuropsychiatric International Consortium on Frontotemporal Dementia. And it was established around 2018. I think one of the first meetings that we have was during the International Conference on FTD in Sydney there. And the purpose was a bit to unite the research centers that had a special interest in FTD and psychiatric disorders. It was established by Jolande Pijnenburg, who's a neurologist in Amsterdam, and by Simon Ducharme, who is a psychiatrist in Montreal in Canada. And so this combination of neurology and psychiatry should be critical for the aim of the NIC-FTD, which is to optimize clinical procedures and differentiate FTD from psychiatric diagnosis. Currently, the consortium consists of around 48 centers and in 18 countries, and there are about 4 general meetings a year. In fact, one of them is today, but every meeting there are new members introduced. So it's quite a dynamic consortium. And here you see a picture of after a consortium meeting during the ICFTD meeting in Lille, and there also the organizers or the driving forces behind the signature initiative are already present. There is Chiara here and a bit in the background. I don't know if that reflects her personality, but Alessandra was also there. The aims of the FTD, the NIC-FTD, are to have, on the one hand, fundamental to advance the knowledge on FTD, and the second aim is more clinical, and which is to improve diagnostic procedures. And the way they want to do this in the NIC-FTD is by sharing data across centers. You all know that FTD is a very rare disorder. So as a single center, if you want to conduct a study that is properly sampled, it takes a very long time. And also this was mentioned during all the previous talks, or most of the previous talks, that the small sample sizes are one of the problematic methodological issues that have been persistent in studies so far. So the way to, or one way to address this is to pool data across centers. And of course, the diagnostic procedures, they do not only consist of social cognition, but the NIC-FTD also focuses on other aspects like psychiatric assessments, MRI, or imaging measures like MRI and FDG-PET. But of course, the main issue of this talk relates to social cognition. And within the NIC-FTD, there are several working groups who focus on a particular topic that is relevant in the consortium, and so there is one working group for social cognition. And so one of the first things that we did in the NIC-FTD was to do a review of the literature based focused on the data that is available, or the evidence that is available to distinguish behavioral variant FTD from psychiatric or primary psychiatric disorders. And so for many aspects, they provided minimal requirements, clinical recommendations, and topics that require future research. And so for social cognition, the minimal requirements that we stated based on the available evidence at the time was that distinction between BV-FTD and PPD should be based not on global cognition screenings alone, so implicitly arguing for the inclusion of social cognition measures, and also to do this by screening based on informant-based history. Regarding the clinical recommendations, they stated to perform at least one structured test of social cognition, and as examples, we formulated the Ekman 60 phases tests, or the C or the mini C. And other topics that we identified that required future research has also been mentioned in some previous talks, and is focused on also the cross-cultural validation, and also the validation of and sensitivity and specificity measures of social cognition tests. And so to address some of these issues, we set up this working group of social cognition in the NIC-FTD. It started with Fiona, Kumfer, Maxim, and myself as coordinators, and the aims were in line with those of the NIC-FTD then, to pool research and clinical data to evidence the diagnostic accuracy of social cognition tests. And this was about the time when the review paper of Alessandra and Chiara in a neuropsychology review came out, stating or evidencing the lack of evidence for a validated clinical recommendation of particular social cognitive tests. So we were a bit working on the same topic, and then this was also the time that we submitted a reply to that study, and we also invited interested centers to join our working group. And of course, the more centers and the more data we have, the more valid the results of any analysis will be. And our second aim in this social cognition work group, in addition to the clinical one, is also to use the data that we will, the data set that we will assemble to address more fundamental questions. And we decided then to use a two-step method, where we would first conduct an overview in all the centers across the NIC-FTD to find out which social cognitive tools they were using in their clinical assessments of patients. And then we would use the results of this survey to select some commonly used tests that we could then do some meta-analysis on, and to formulate maybe or to calculate some diagnostic accuracy measures. And so actually the reasoning in this group, in the working group, was that we do research, or most of us do research in the social cognition in FTD, and we have all our data from our scientific studies, but we did not use them or exploit them, if you want, to optimize clinical practice, but in fact we have the data. So it should not be too much effort to pull them and extract some diagnostically relevant information from that. We will see if that was indeed the case, that it was not too much effort. So for our first step to do the survey across the consortium, we designed or we set up an Excel sheet, and we know everybody has very little time, so we wanted to make something that was very user-friendly and took not so much time to complete. And so this is basically what you see here, how the Excel sheet looked like. So we asked the participants first to look for, in the first column, to look for the instruments that were used in their center, in their either their clinical workup or the scientific studies that they did. And we then grouped them into the main subdomains of social cognition, emotion recognition, theory of mind, and empathy. And then we asked them to indicate or to provide a rough estimate of how many patients between the age of 45 and 75 were assessed with the instruments in the last 5 years. And we asked them to provide these numbers according to the diagnosis. And so we had some neurodegenerative disorders, FTD, Alzheimer's disease, Lewy body disease, posterior cortical atrophy and Parkinson's disease, and vascular dementia. And then also important for the consortium was the primary psychiatric disorders that were a relevant differential diagnosis. And then, so the idea was that each participants would fill in the number of patients with this diagnosis that they had evaluated with one or more of these tests. And then as kind of an optional question, we asked them to indicate how many or what the proportion was of patients that had biomarkers to support the diagnosis. That took a bit longer than we anticipated, but still we have completed our first step in the survey, and the results you can see here. So here you see the most common tests that were used in the consortium in the middle column, and then on the left you see the number or the width of the bars reflect the number of patients, the number of cases which are color-coded according to the diagnosis, and on the right side you see the same but color-coded according to the center where they were assessed. And so based on these data, we made a selection of tests that we would focus on in the second step of our study, where we would do the meta-analysis on. And the principles that guided our selection was that, of course, what was important for the selection was the number of cases that were evaluated, because like some tests here, the feast, for instance, only very few cases were available, so it makes little sense to include that, of course, but also the distribution across diagnosis. For the NIC-FTD, or particularly in addition to FTD, the number of primary psychiatric cases were relevant. And secondly, or thirdly, another factor that played a role in the selection of the test was the distribution across centers. For instance, what we saw, what we noticed was that for the frontal behavioral inventory, for instance, a lot of cases, FTD cases, were available, but they were mostly from a single center. So if we were to do a meta-analysis on this, I think the addition of more centers would actually reduce the quality of the results, because we introduce more heterogeneity in the data. So it would make more sense to do the analysis on the data from the single center in this case. We also wanted to focus on true social cognition tests, so not on, for instance, the geriatric depression scale or the neuropsychiatric inventory. And then we decided to focus on 3 tests based on these predictions, or based on these principles. So the interpersonal reactivity index, the FOPA test, and the Ekman 60 test. So you know, the latter 2 are the ones that constitute the mini C, developed by Maxime and Berthaud. And so now we are at the second stage, and we have again designed a data sheet that we sent around to all the centers that have data available on at least one of these 3 tests. And so this data sheet looked like this, where they had to first identify the patients and then indicate the diagnosis of the patients, and then some demographics, the scores on one or more of the 3 social cognitive tests. And in addition, we also asked for measures like from other non-social cognitive neuropsychological domains, So for we have to indicate the MMSE score, the total score, and also the score by subdomain. The MOCA digit span, some of the most or of commonly used tests in the conventional neuropsychological evaluation. And then, so now we are at this second stage where we want to collect the data first and then do the analysis. And there, or here we are experiencing again some roadblocks, particularly the administrative, legal, and ethical issues are very time-consuming to address. And also, this is not, we are researchers or clinicians interested in social cognition. We are not very happy to spend our time in designing legal documents for data sharing and all these kinds of things. So this is a bit a blockage now in the procedure for our study. They are designing, or currently they are preparing a central data sharing agreement in Amsterdam. And once that is finished, we hope that we will be able to continue with collecting the data and performing the analysis. For one of the previous projects, if I'm correct, it took more than a year, especially with the US, to get all legal and ethical issues in order. But then what we want to do with, once we have the data, hopefully very soon, what we want to do with it is to also first extend our data pool with data from primary psychiatric disorders, because most of the data that we have are from FTD, and there is a bit of an underrepresentation of cases with the primary psychiatric diagnosis. We want to calculate the diagnostic accuracy measures, but also, and that is why we ask also for this MMSE and other cognitive test score, is that we would like to apply some tools that have been developed in the machine learning field, for instance, like pattern classification and so on, to apply that on our data set. And in addition to that, we want to use our data sets to answer more fundamental questions. For instance, as some things that have been mentioned in the previous talks, also the cultural differences is something that is of interest, or that our data set would provide a good opportunity to investigate this. Cultural differences, well, we have to be relative about that. It's mostly Western data that we have, but still we can look at differences between Western societies, for instance. We can also investigate associations among social cognitive subdomains. And the idea is also that we will use the results that are derived from this retrospective study to design prospective studies, in which the consortium would also be a good vehicle to collect a lot of data once we have a new tool that we would like to test. So some suggestions I have based on our experience for the signature initiative is, of course, to start early with, or at least be aware of all the legal and ethical procedures that are associated with data sharing. This is so currently the main bottleneck for the social cognition work group of the FTD, and also all the work that we are doing on social cognition within the NIC FTD is in our own time. I mean, we don't have any funding for dedicated researchers to do the work. So that is also something that maybe a slowing factor in the process. And yeah, finally, I think this may also be a good platform to ask you if you want to join our initiative. And we, of course, the more data that we have, the more valid that our results will be. So if you have data, social cognitive data on one of the 3 tests that were selected for the second step, I would invite you to, if you are interested, to contact me, and then we can see what we can do if you are interested to contribute to the project. So then I will end by thanking the members of my lab and our collaborators, and I'll be happy to take any questions.
Very much. We are a little bit late, so if there is a quick comment or question. No. Oh, okay. So thank you very much. And we share your frustration, as Alessandra said, also for the legally problem that in Trento are particularly difficult. Okay, thank you very much. And let's see. Was the last talk of the session.
Just to let you know, there is a coffee break now, so it is on the first floor, and we will be there. So in 30 minutes, and we will start again with the second session of the morning. So thank you for those who are online. We will be in 30 minutes.
Okay, everyone, I think we are ready to start. So we move to the next session of the morning, which is harmonization of socio-cognitive assessment in neurocognitive disorder. And the moderator is Sarah McPherson, so thank you very much. She's a full professor of psychology at the University of Edinburgh, UK, and national lab coordinator for signatory initiative. So thank you very much.
Okay. Is this on? No.
Yeah, okay.
Okay. Hello, everyone. Thank you to Chiara and Alessandra and the Signature Initiative for inviting me to be here. I'm really excited to be part of this workshop. So first of all, we are going to ask Marina Boccardi to talk about some of her work and the title, Where We Started From, Harmonizing Cognitive Assessment Across European Memory Clinics. Thanks, Marina.
Thank you. And thanks, Alessandra and Chiara, for inviting me to this important meeting. So we like to think that this initiative started from a workshop that we had in Geneva in 2018 on the harmonization of cognitive assessment, and I will give you some details of what happened there and the direction for socialcognition. However, to be true, this work actually started a little bit before, and beginning the work by Chiara. So in 2017, she published this paper where she assessed the evidence available in the literature on the development of tests for free and cube recall for the detection of Alzheimer's disease. And for each of these validation steps, she assessed the literature and said if it was accomplished or not yet. So this framework was an idea actually of Giovanni Ruzzoni. He imported this systematic methodology for the validation of diagnostic biomarkers from oncology and transformed for Alzheimer's disease. And what is this? Briefly, this long flowchart basically consists of three main pillars: analytical validity, demonstrating analytical validity through these many steps. That means in this test, we are really detecting the pathology of interest somehow. Then clinical validity. With this measurement, we managed to pick the clinical disease in patients as early as possible, and then demonstrating clinical utility. Using this test is cost-effective and brings benefit to patients. So for all of these flowcharts, all of these steps, they are accomplished green or preliminary, partial, yellow or orange, or not yet investigated, not accomplished. And this should be done in a sequential order. If we have green here, it's worth nothing because actually we have a guess. So I would bring your attention to this step in the analytical validity pillar, that is defining a standard operating procedure, defining how the measurement could be done. So among the many recall tests that we have, visual version, verbal version, verbal with 5 words, verbal with 26 words, whatever, if all of the subsequent studies use a different test, we incorporate in all of the validation pipeline an amount of variability that we are not able to amend afterwards. So when clinicians, associations, policymakers, FDA, whatever, have to make evidence-based decisions, shall we use this test or not? The result is inconsistent because we use different tests and the evidence goes in different directions. And so there is no evidence supporting the utility of this test, even if the test is actually valid in our so-called clinical studies. So this is why this box should become green before doing anything else, because otherwise all the rest is just useless and to the aim of implementing anything. Like Chiara, Other researchers perform exactly the same kind of assessment, now putting lines, the same boxes sequentially for any other biomarkers. And okay, you can see green scattered everywhere, but I would bring again your attention to this as a secondary aim 1, that is defining an assessment in the same box. So, okay, we can see some green in a couple of boxes. CSF had first evidence of supporting the Alexis and the platforms for good, valid, systematic assessment of CSF. It was the beginning. Now it shortly became green. As I said, this green afterwards because nothing should be redone with this measurement, because otherwise it was inconsistent. But what struck me at the time was that even if we had standard operating procedures for all of these boxes here, for all biomarkers, even if all of these were green, all of the studies for even within each biomarker would perform their studies, their validation studies on patients that are selected in different ways, based on different definitions of CI, based on different cognitive batteries. This means that again, at this step, at this very early step of development, we are incorporating an amount of variability in the data that is propagated in all of the other studies, and again, spreads results, blurs findings, blurs the signal, and invalidates basically the whole pipeline going from research to implementing in clinics. And this is really where we started from this evidence. And this is why Swiss National Science Foundation, a couple of other funders, European Alzheimer's Disease Consortium, and other Swiss institutes thought it was important to support the workshop in Geneva to harmonize cognitive assessment as a very preliminary step. So I proposed the initiative for clinics. Why? Because if we harmonize assessment in clinics and then perform clinical research on these patients, we already have a standardized assessment. And so we benefit at once, clinics and research. And think to the waste of money and effort for patients. If a patient wants a second opinion or needs to perform a follow-up in a different clinic, in a different city, this patient will need to repeat the assessment for the baseline. If we had a standard assessment, this patient would just go with these results and ask the specialist, what do you think about this? It would be exactly the same tests that he would do again. So big benefits for research and for clinics at once. So I invited lots of people, experts of the main previous harmonization efforts from Australia, US, Europe, wherever. I won't give many details. I added additional slides at the end, or you can find in the paper. And what happened there is that Andreas Mosch proposed an idea. He said, when we started with all of the best of our methodology to do something good and evidence-based and whatever, but he said, hey, look, in US, the NAC, the biggest network for Alzheimer's research, already worked a lot to overcome the limitations of CIRAD. That was the most widespread standard in neuropsychological assessment, at least for research purposes, but also in clinics in many contexts. And they worked to improve sensitivity for mild cognitive impairment. So they said, rather than doing this work again, even if we may do something better, but why don't just import this standard that is already most widespread in US research? And we all agreed in this implementation perspective, we don't need to do to create a new standard. We have to bring the standard to clinics. So if a good standard is already there, everybody agreed to import it and to somehow adapt it to European clinics. So this is our paper, our product. We call this the clinicians uniform dataset, like UDS3, uniform dataset 3. And we just made a few very little changes to adapt. So what did we do there? As I said, you will find more information in additional slides, but very briefly, we used an informal consensus procedure. So we had a wide consortium and we had thematic working groups. Chiara was, for example, the leader of the neuropsychological working group. And wherever there was an issue, the thematic working groups were tasked with finding out evidence, proposing a solution, and resubmit to the whole consortium who would further discuss or ratify this proposal. And what did the group generate? They first defined the context of use. Context of use is very important. So we need to just be as sensitive as possible in detecting cognitive impairment in anyone who may have a neurodegenerative disease. So, of course, the limitation there was that most batteries were centered on Alzheimer's disease, but in memory clinics, people may have any other neurodegenerative disorder. And another issue here is that even if we have the best team of neuropsychologists and the most advanced instrumental tools, if we perform a classical assessment of patients without etiological biomarkers, our diagnosis is wrong in the 30% of cases. And this finding has been replicated many times along decades. So there is nothing to do there. If we improve neuropsychology, we are not going to improve this range, unfortunately. So we decided that the function, the context of use is just to say, yes, this patient should continue in the diagnostic procedure, possibly biomarker-based or not, to decide whether to spend money, public money for this patient. And then the group defined very nicely a definition of normal controls, the methodology to collect data for normative values for the test. And this is very nice because this methodology allows to perform very advanced statistics for obtaining normative data, and can be used, should be used across languages, across cultures, but also across tests. Ideally, this methodology could be used in any new test and have always harmonized normative values across all neuropsychology domain. And then, of course, we come to the battery. So, as I said, we just imported the US uniform dataset, the NAC uniform dataset. This is made of tests very, very commonly used in clinics. They actually recreated these tests in order to overcome copyright issues, but the tests are exactly analogous to digit span, trail making, whatever. We substituted the logical memory test with the free and acute selective reminding test that is more specific to Alzheimer's pathology, and that was European born. So this is, of course, we had to do something European in this occasion. And crucially, we added, thanks to Leonardo Sacco, who is here, who reclaimed the need for a test of social cognition. And we used the set developed by Alessandra as a feasible and quite a language independent test that was possible also for patients with little compliance, like patients. For the rest, it was the same sort of test. You will find more information. I go directly to the discussion. So again, is all this necessary? Well, a test of social cognition is not only required by DSM-5, as we heard already, and allows to pick even early failures in patients with degeneration of the frontotemporal lobe degeneration group, and possibly also atypical patients, but there are, as we heard, also Lewy body patients or vascular conditions that may have this sort of impairment. So we want to be very sensitive in picking anyone who may have a neurodegenerative condition. I already said why harmonizing is important for clinical and research. All these harmonization would also allow to align clinics to what is developed is being developed in clinics immediately. So the recommendation for prescribing a biomarker of treatment would be automatically aligned for the very same kind of patients. And I would end with this slide. Am I here to promote the implementation of this standard? Well, maybe the clinicians' uniform data set is maybe better than previous initiatives. For example, these JPMD or the Chinese initiatives are actually very long lists. Whatever is available there, no clinician can really apply the Chinese, but it's all existing tests. Maybe our effort is actually worse than other efforts that go much more in a transcultural direction. We try to be language independent, but didn't manage to do much. So basically, we try to propose the visual version of the PhD selective remaining test, but the psychometric properties of this version are weaker than overall. And so again, we are very language dependent. It's important to go in a transcultural direction because even within the same country now we have so many different cultures. So here, frankly, I am not saying ours is the best effort, but the point is, if we had here now an expert of health technology assessment, and we compute how much money is wasted in inconsistent assessment, in research, in clinical research, and in clinics, this would be a huge amount of money. We really don't want to see this money, public money, wasted in this way. And so at some point, and this is a recommendation valid also for the picking a test of social cognition, we can always do better. Today, so many people tell me, Maria, now we have digital tests, we still have digital tests, okay, but these still have to be validated. And when they will be validated, we will have something even better. We will have the feeling of the facial musculature, picking it from what comes around. I mean, we will never harmonize anything. So we are very good basic researchers. We are a bit less efficient in implementing. At some point, we have to make a decision to freeze good practice as it is actually in our clinics today. And today we're still doing paper and pencil tests. And so we have to freeze some good choice, implement that, and then we will evolve and keep this double trail. And this was also a recommendation in our harmonization paper. Keep always the double trail of developing better and better tests and procedures. And so with this, you surely understood that I should thank many more people than the co-authors of this paper, many more. Many thanks to Chiara and Alessandra for leading this brave and important initiative, and to the team, Bobby and Andrea. I am always impressed how creative and efficient you are, and thanks to all for your attention.
I press. I didn't notice. So is it this one?
Yes, this one.
Okay. Thanks, Marina. We have time for quick questions. Simone?
Very interesting work what you've done. A couple of issues. One is the gap between what is the harmonization and the diffusion of the instruments, because some steps should be taken to disseminate the results and disseminate the instruments. I required several times the possibility to use the test. I every time faced no way. You must test before the instruments are probably someone else. The other issue is the normal controls. How you choose what's normal?
Yes, so for normal controls, for example, we have, you will find a slide, an additional slide and criteria in the paper. They are very nicely detailed. So for example, we decided not to have hypernormal. We don't want to have biomarker negative. We want to have clinically normal people. So, and you will find more information. Of course, no interfering pathologies, trauma, and so on. authorization is a huge point because, for example, Stefano Campa managed to have an authorization to recreate the same test of the uniform data set for Italy for IRCS institutes. But indeed, if we want to import the same test as the NAC, I don't understand, because they supported the initiative, but then it's difficult to, because, and this is really a system problem. If we have to improve and implement, there must be some ecosystem changing these sort of things, because there are commercial interests and so on. So my recommendation is, if we want to harmonize this way, just use the local equivalent that exists already somehow and buy it from the original developer.
Thank you. And yeah, don't run away yet.
No, just a comment. Thank you, Marina, because your perspective is always illuminating, because it's completely the opposite and different. And I think so. One question is, in your experience, how much do you think that the family association can push the process? And this is something, because I think that otherwise, biomarker, founders and so are not really considering your perspective. And the other is something about the education. So, because I don't know if the biomarker experts, I've been at the AGPD conference, and it was biomarker based biomarker. I was in other conference, and I think they are not aware of this, of the fact that we select patients on
They are aware somehow, but there isn't.
That shows the process of knowledge in that community.
Yes, I mean, this is the focus of my job to create the ecosystem, because there is no ecosystem basically. There is no communication across different stakeholders. So the more we are all aware of this need, and the more we have the tools to explain why it's important, and the more we can go in that direction. It is a slow process, but it needs to be done, and bring stakeholders together. And the first question was the family associations also would be powerless if they are not brought in a systematic ecosystem, because everybody would be alone. I am alone, you are alone, they are alone. So we really need to build the infrastructure to promote this. We are slowly working on that. Thank you.
Thank you. And now we have Simone Pamati, who is a clinical researcher at the neurology unit at Luigi Sacco University Hospital in Milan, here in Italy. And Simone is going to talk about cross-cultural neuropsychological assessment in Europe.
Thank you, Sarah, for my introduction. Thank you, Chiara and Alessandra, for having me here. I am speaking about quite a different aspects, because we must consider also cross-cultural issues. Where are we now? We start quite from the end. 2 points. The ECRON, which has been somehow cited by Marina, and the imminent problem. ECRON is a consortium who has been created in 2019 here in Milan, in Italy, by a small group of researchers with the aim to share information and to go on and include as many researchers as possible in the context of cross-cultural assessments. And which are the aims of the ECRON? That to provide a general overview of the challenges and the status of cross-cultural neuropsychological assessment we are speaking in. And the other to present the same points and the potential impact of the consortium on the research and the clinical aspects. The other side is the imminent project. The project is a national project who has been supported by the National Ministry of Health of Italy, and has recently been refunded. We have had a 3-year research, and now we have started from a new one. Which were the objective of the project, were to characterize the issue of dementia among immigrants and ethnic minorities in Italy, and to contribute unique data on dimensions and features of this emerging phenomenon, trying to document possible inequalities across Italian regions and services. It's a great project, and nothing else has been done so far. Where did we start? Even this has been started by Marina, and it was a survey conducted by Nielsen, which is an expert from Denmark. We were in Copenhagen 2 days ago to discuss this project. We conducted a survey among the European Socialcognitive consortium to evaluate in how many cases they had to do people with culturally and linguistically different problems, and to see which were the challenges and which were the possibilities to improve. A second survey has been recently finished. It's not been published yet. Rune 2 days ago presented the preliminary data and showed that some differences are becoming aware in the next year. What has been studied was some special related to patients which had to do somehow with culture, educational levels, linguistic abilities, also religion and attitude about health and health institutes and the ability to assess systems, and which investigation could be done and which were more problematic. And you see that often problematic were cognitive testing and psychiatric evaluations. Culture and awareness were big problems among researchers. In many cases, researchers said that they never faced the problem. We did not see any migrants. In France, they said a totally different thing. If they can speak French, it's not a problem. Services are lacking cultural awareness, and there are problems in sharing also the languages. The other problem is the concept of dementia and the concept of cognitive impairment that is based on traditional regional society and is very linked to family network and stigma represents the respect. Over different countries, dementia can be due to disease, can be thought to be due to disease or aging process, or even to God wills or fatalism. If dementia is something that has been sent to us by God, I should not do anything because it's sacrilegious, or something to do with supernatural experiences, kind of pre-death, or something with negative rewards. If I do something, maybe it goes against me. Claricadia, which is one of the founder members of ECRON, has published an interesting paper in which she showed the different ways of thinking about dementia in the United States, China, and Britain. Clara is an Italian researcher who is based in Edinburgh, and also she shares different cultures and linguistic aspects. In 2019, we had begun with this study, someone before also cited this paper, in which some friends and also one of the founder members of ECRO had proposed this kind of question, which was the frequency of patients CAT stands for culturally and linguistically different patients in clinical practice, which were the largest ethnic groups, which were the most common educational level of the groups, how cognitive assessment were done, were there the tests, were there notes, who were the examiners, were the interpreters used, paid, how the training was made, and which cognitive domains were studied. And you see, social cognition was one of the issues that was proposed 4 years ago. For all the cognitive domains scored lower than 7 over 10, there was a question, how? You see that in the centers included, centers were in several countries of Europe, for Italy it was me. The amount of CAD patients were about 10 to 15 patients. Education was quite low, and overall, people came from Turkey, from North Africa, from other countries of Europe, mostly of Eastern Europe, and from South Asia and Dutch natives. We must consider that in Netherlands there are great ethnic minorities from South Asia and Antilles. And in Rotterdam, where Sanne works, she is a specialized neurologist that sees only patients outside Europe. The result of the study was that more knowledge was needed, and the effort was needed to go together and to share the awareness and the training. So the aims of the ECRON paper published 1 year ago was to go towards a broad definition of measurement of diversity, taking account lifetime demographic and structural factors, to support the use of widely applicable first-time tests as opposed to what's done in the United States, for example, such as race-based norms. If you go to read USA literature, you can find comparisons between Latinos and white people, but it's not very good. And clinical training. The other aspect I was talking about is evident. We had started in 2017 by initially going to see what happened in our hospital in Milan is set in a context where large minorities from different cultures and languages present. And the group of Marco Canadelli and Rome had done the same things. And we have published separately our results. And overall, in the context of the limited study, we have got to estimate prevalence of dementia and cognitive impairment in Europe and in Italy. A survey was conducted in Italy involving all the centers for cognitive disorders and dementia who had participated in the CRONOS project and was recognized by the Italian Ministry of Health. And a large majority of centers decided to participate in this survey. You see here the representatives, and you see that in some countries, in some regions of the southern part of Italy, there are problems. Well, which were the results of this survey? It's a survey, it's not real data, it's an impression of data. That migrants were poorly represented in everyday practice, and in some cases, neuropsychological assessments were done in patients' cultural and linguistical differences, but so far there are no information on how these assessments were done. We have also asked if some figures were available in clinical practice, such as cultural mediators, interpreters, social care works, and see if there were differences in them. I said that funding for imaging has been set again, and now we are starting with real data, see which are the demographic, social, and clinical characteristics of patients to provide healthcare professionals for the tools for cultural cognitive assessment and to raise awareness on and help to fight stigma and train health workers. These are the data from our centers updated to 1 month ago. The last month I've seen some more patients with the cultural linguistic difference. And you see the increase in referrals of patients with another language or other cultures. This schema shows how many languages we have to face. Much about South American Spanish is a common language, but it's not a common culture. You see how large is South America. And you see how patients come from mostly South America and mostly from Peru, but North Africa, Eastern Europe, and everywhere. In some cases, we had the possibility to assess patients with screening tests, just more with us. And in other cases, we had conducted a complete neuropsychological assessment in the last 2 years with the release of cultural indicators. The results of the psychological assessment we must consider that are complex interaction between brain and behavior, and considering that in different cultures, the performance of the cognitive activities are different. In Western countries are based on objects that are relevant or categorically related, and Eastern or South world countries are most related similarities of contextual days. And example, if I test the questions as in the mocha, why are an apple and say train and a bicycle similar, and they tell me that they have this. It's not wrong, it's the way of reasoning. It becomes wrong when I explain how I want to make a reason, but we must consider its. There are many cultural variables that have a significant impact on your psychological performance. Some that are based on how we learn to do things in school, memory, reasoning, and some other that are related to family, interpersonal relations, social status, religious belief, all things that go towards social cognition. Acculturation is another aspect. Acculturation is a complex feature and it's difficult to measure. There are people who live here but that are not integrated. In Milan, there is a large Chinese community. Chinatown is a great part of Milan, surrounded the different side. There are people from Chinese origin that are there since 50 years ago. But they don't speak Italian, they are never integrated. We see few Chinese people because they don't come to the country. When we consider acculturation, why are we considering that? We are considering competence that the cultural interactions, competence in the mainstream cultures, what are we doing? I said 2 days ago where I will in Copenhagen. That's the basic choice. Which is part of information. In Italy, you say no, but you say also no. In Denmark, they say no. It's different. We must change our paradigm. We must change and go from Western educated, industrial, rich, and democratic to eclectic, where education, culture, language, economic history, communication style, intelligence and complexity immigration are all relevant information. When we have to adapt tests, we must consider country of origin, language, and the interaction between them. And we can translate that, or we must need to adapt tests or to start to do with someone else or to change overall. You have already had the slides, and you can see the complexity of adaptation of natures. I don't stay on the slide. I stay a little on this because they consider the problems of measurement. What are we measuring? Errors. How are we made? How many errors? Is the test valid? And what can we do? we should try to build some kind of specific tests, if it's in utopia. How can we measure changes? Maybe considering aspects different from what we are used to, considering statistics aspects such as item response theory or differential item function, something in which machines and maybe artificial intelligence can help. And we must go to look at the quality of the data and qualitative aspects of performance. Where are we now? What are we doing in Europe? We are working on epidemiology and looking for the needs of the people. These are the countries which are more relevant presenting research in this context. Also, another aspect is the awareness and the possibility to overcome the barriers and the development of the adaptation of some different tests, but also to consider how to build the norms and consider special patients even within different countries. I discussed the example with a colleague who was in Bolzano, which norms she uses in Italy, weird country. And she says that she uses norms that were built in Austria. Totally different. Where are we going? I hope next year we will all go to sport. With the Global Neuropsychology Congress, we can see the aspects of the other cultures. There are societies from Asia, from Latin America. See there. Thank you for your attention.
Thank you, Simone. Really interesting work, really important work. Do we have any questions for Simone? Any from online? Nothing from online. I guess one question I might have, and we have kind of discussed this during the break, is that I think in social cognition, cross-cultural issues are probably have a bigger impact than some other aspects of cognition that we assess. Do you think that you can take existing social cognition tests and adapt them for other cultures, or how do we deal with the cross-cultural differences in social cognition assessment?
In the first aspect, we must consider in which cultures are we deciding to use social cognition techniques and why are we deciding to use them. The review of the literature on social cognition measures is going to be published by Mundara, who is the ECHO member. And he has found that there are no measures of social cognition developed as should. We find also searching in databases that are beyond psychiatry and PubMed and so on, looking for South Africans in Latin America, so on. No measures, no study in these questions. This is the big problem.
I agree with you because when we was invited by Fiona Camphor to do a webinar for the Society of Social Cognition International Society, and it was we had a comment from a colleague, a clinician from South Africa. And so there is no story, no story of nothing. No, there is no process, no road, so this is quite impressive because we talk about globalization and we talk about international initiative, but obviously we are not considering the whole And so I would like to ask you some suggestions, and I hope that you will give us a lot of suggestions and a lot of comments in the second part, because we need also to fill this gap in the cross-cultural assessment. So in our situation for social cognition with the immigrants in Italy, so we had some with you in the project with Marco Canevelli, so some evidence of the battery that.
At present, we have no data because also in our clinical practice, I have one of the centers which is the majority of patients with linguistic and different culture. We have not the possibility to study. Not rely on their relatives tell us and which is the relevance of the changes on behavior and the relatives.
I have another. Do you think that caregivers informant questionnaire will be better in this sense than patient's task? So will be easier, will be something.
I think they should be together, but also in this case considering how the relatives of the patients consider the problem, how they see it, and how they want to show you. An example, I worked last year with a theater teacher who has worked a long time in Japan, which is a weird country. They're not white, they're rich, democratic, so on. And the behavior of the Japanese society is strange. They do not show you what they think. Mostly if there is a Japanese who is talking with a non-Japanese population. But if they, two Japanese, talk together and think that you do not hear them, they say something about you that's not so good.
Okay, thank you very much, Simone. Okay, so next we have Chiara Cerami, who is an associate professor of neurology at the University School for Advanced Studies here in Pavia and coordinator of the Signature Initiative. So we all know Chiara. And she's going to talk about the need to fill a gap, aims and foundation of the Signature Initiative. Thank you, Chiara.
Thanks for the introduction. So I will be brief. So, but we so the first time we decided to put also this brief presentation to do a recap of the brief history of Signature, because I think that it's useful. So Marina have already introduced the fact that all starts from Geneva. So even though but all starts with we discuss with some discussion. So in neuropsychology field there are always discussions, and when we discussed in the group of neuropsychology of the Geneva harmonization, and the group was in the group there were Stefano Kappa, Bruno Dubois, Andreas Monch, and Jean-François Demonet. So certainly social cognition came up as one of the important core domain that should be assessed according to the DSM-5, but also according to the evidence that has been growing in the field of experimental neuropsychology by looking at clinical population. And I think that it's important. So, so linking to what Jordi mentioned, so DSM-5 suggested preferably the assessment of these cognitive domains with the quantitative measures. Okay. So, and when we looked at the table of symptoms and observation that has been reported in the DSM-5. So we had the idea also, or probably it's too small to see, but there is a brief description of what is, which can be the symptoms and observation in major and in mild neurocognitive disorder. And when we see, if you look at the description of major, so behavior for the social cognition domain, so we are looking at this. So behavior clearly out of acceptable social range and shows insensitivity to social standards. And also, but also, for example, there are so other decisions that are without regard to safety. So something that is quite also impressive from a clinical point of view. But when we look at mind, the description is just subtle changes. But when we go to the early phases, so mild behavioral impairment or the mild phases of dementia, of course, the question of the quantification of these changes is more important, certainly. The example of the assessment is that in the description, in examples, there are the recognition of emotion and the recognition of theory of mind, and the use of theory of mind tests. So certainly it's evidence in these two phases more. So what we can conclude looking at this background is the fact that certainly there is a major focus on the need to identify alteration in social behavior rather than in the definition of specific phases of so-called impairment, the deficit of specific phases of the social cognition domain. And then, but even though this is relevant information, so in mild and major neurocognitive disorder, this for the DSM part at least. So it's relevant mainly for the description, the early description and the differential description of what is the frontotemporal aspect. But considering the evidence of this morning, so probably there is something more. So we have to move on. So for those reasons, we decided to put also to consider also this cognitive domain, and according to our experience and our expert opinion of that time, at that time, so this time was the 2019, 2018, maybe before, so the time of the consortium in Geneva, we decided to include one of the social cognition tests, so the surveys and tests, because of the high phase validity, the fact that it was created for the neurocognitive disorders, not adapted from part of starting from psychiatric disorders. So it was to one point, and also obviously as Fiona said, so the low language in memory or the low load in language and other cognitive function, and the fact also that it is free. So this is a very good point. Something that also we do not consider in the daily life, but it's very important when we think about the methodology. So the public money that lost. So and also thinking about the fact that we move into a digital world where companies have products, have solutions. So, and the fact that we should recommend tests that can be used not only by the weird countries, not only by those centers with money, but also with the by centers, by primary care. Also, it's quite important. So the free knowledge, the free use, it's quite important. Okay, so starting from that, so when we published the paper, so a discussion was open, so a dialogue, and it was a very something that very stimulating for us. So obviously we expected some kind of reaction, and I thanked Ian that started with this commentary to the paper, and his commentary, of course, he discussed and underlined the fact that probably in the assessment of the minor cognitive disorder, which was the aim of that initiative, so the deficits in social cognition we have poor information in the routine investigation. And this imbalance between the experimental field and the clinical field, so is an important issue. So the translational efforts is something that we have to consider and we have to overcome. And the promotion of collaborative effort initiatives and putting together also different backgrounds, clinical researchers, it's something important in order to optimize this process and to fill the gap. So obviously we replied to this and we agreed basically with all the points, the critical points. What we proposed at that time was the fact that so basically two points are the most important things to. So one is the fact that there is lack of multi-center study, there is lack of comparisons, and open very complex discussion on the heterogeneity of the population that are included in the study, on the heterogeneity of the background, neuropsychology assessment, clinical assessment, and then all the biomarker, the heterogeneity of the biomarker. But then also cross-cultural elements into discussion. So we need more international approach. But in this approach, this is a topic for researchers. So I think that it is a topic for researchers. It's a job for researchers, but we cannot avoid to put in the center. So the family association and the clinician, the final users. Also the psychologists, the brilliant final neuropsychologists. So because they have to change at least or to decide, change their practice or decide what which path to follow. So in May 2023 started this initiative, so-called signature, because of this is the acronym, the explanation. So the clinical use of Socialcognition matrix for the assessment of neurocognitive disorder, and included both experts, researchers, methodologists, of course, but physicians, psychologists, so psychiatrists, geriatricians, because there is another issue. So the fact that in Italy, so the large majority of memory clinics is a balance between geriatrician, so led by geriatrics and or led by neurologists. So, but in Germany, for example, so it's also 70% psychiatrists. So the perspective changed. So when I was in Cologne, I discussed about this with some colleagues, and the perspective is completely different. The perspective on social cognition, on the use of neuropsychology, and also on biomarkers. So this is my opinion. I don't know, Marina, of course, has large experience. So but it's quite important to think about who we are. And then finally, the family association. So main aims of this very complex initiative So the basic aim was to create a community with a specific interest, with the same specific interest, and there is the promotion of the use of this task of social cognition task in assessment in memory clinics. Okay, this is basically what we decided at the very beginning. So we decided that we have to put social cognition in memory clinic as a relevant issue, at least as Alessandra said. There is also social cognition among the other cognitive domains. So this is something that is very important to reach as objective, as an outcome at the end. So identifying clinician and also stakeholder family, patient caregiver needs. It's something that is quite important for me because otherwise we cannot have this. We cannot rebalance this distance between experiments, between researchers and clinicians. So the patient can put all together. So and at the end, for the benefit, of course, of the individual, but also of the society. So we are moving together. So the first aim is certainly to define which is the state of the art. So we have to know what we do in clinical practice in the different countries. First to decide, not to move to that methodological process. And in this process, Marina was very important to give us a view of how to do this. It's important to have a look at the perspective of clinician, the perspective of family, and evaluate the state of the art in the different memory clinic. At the end, to reach, of course, with the expert opinion recommendation and move on with the next step. So we started in May 2022 with 50 participants. So the community of the Geneva initiative, so with this group coordinating, and obviously we relied on the important support and important vision of some advisors. So basically the advisors of this initiative for us, of course, were the quite experts in this sense. So the young mentioned that the NICFTD did a lot of work in this sense, so in this field. So here, Simber too and Fiora Campro became advisors of this initiative at the very first beginning. So we started with 50 participants, 8 countries, and 50 institutions. So now we are in September, looking at this, we are in September 2023, right? So we have joined, so people who joined the consortium, so there are 140 participants, 18 countries and 19 institutions. But more importantly, I think that there are national hubs. So we decided to have such a pyramid of this joint effort. So with the coordinating group, of course, with advisors, but also people who are in charge of those which are the main aims, the main problems, the main obstacles in each context. And people can have also a better perspective on this. So I thank Sarah, who is coordinating the UK and that hub, so Georgia, Spain, the Portugal, and so on, also the Italian people, the Switzerland group, so in presence, and also for those who are in remote. The roadmap that we decided, and this is on the website, so you can have a look later. Is so the main step, the main brick, the basic brick is to create the consortium, then move to see which is the situation, the state of the art in the clinics. So looking at, with a focus, looking at the clinics, so when, how, why to assess social cognition in cognitive disorders. Then with this information to have some kind of recommendation in a consensus of including also experts. And this is what we are trying to do now. Then, so we will at the very first beginning, we decided that this was such a path in progress, okay, with just one direction. Now that are in the middle, so I think that there are different trajectories of this path. So we will change it to the website this video. So one, because I think that in parallel. So today we open different problems. So we open educational issues. We discuss about educational issues. We discuss that are something for the community, for the cognition community. Some issues that are basically related to the experimental psychology. So we discuss about paper and pencil and the digital solution. We discuss about the ecological. So we discuss about more phases. So phases related to single specific research question, and phases that are more they involve us more in a more broad way. So I think that the road is certainly much more longer than what we at the beginning with with a lot of enthusiasm design. So, but to conclude, I think that so it's for me. I work both in clinics and research. I think that when we look at neurological populations, so. Nowadays, so we cannot have a combined view. So looking at bottom-up needs, so clinical services, we are discussing another table about the disease-modifying therapy in Alzheimer's disease, and we cannot consider the fact that we have some services, some neuropsychological services, some neurological memory. So the structure of what. The work that we do in everyday life. And this is an information, a knowledge that came from the bottom up or audience. And then obviously this is combined with the top-down knowledge of the experimental research. I think that in this view, so the international scenarios is quite important to have a better knowledge in this, a better advancement in this. So I can put also a very long list of people who have been involved, and I want to thank for this long road. And I think that so without your effort, nothing would have done. So it's quite important. I think I will thank you at the end.
And thank you to Chiara and Alessandra and the rest of the signature team for starting this important collaboration.
Yeah.
Okay, we'll move on. People can ask Chiara any questions over lunch, I'm sure. Okay, so the final talk we have is Andrea Panzavolta, who is a PhD student in cognitive neuroscience and philosophy of mind at the University School for Advanced Studies here in Pavia, and a member of the Signature Initiative coordinating team. And Andrea is going to present the Signature clinical survey results. So I'm really excited to see the results now.
Yeah,
Thanks,
exactly. Thank you so much, Sarah. Thank you so much, everyone, to be here. Well, I know you probably want to lunch, but please don't drop. This is the final session of the morning, and then we can do everyone to lunch quickly. So, as Sarah said, I'm going to talk about. Sorry, just a minute. Okay. I'm going to talk about the results of the signature clinical survey. First of all, this represents the signature roadmap that you have already seen during the presentation of Alessandra and Chiara, but I will focus on the second step. In particular, I'm going to talk about the when, the how, the why assess social cognition in memory clinics through the presentation of data collection result of the clinician perspective. So, starting from the consortium creation and in order to collect data from the memory clinic, we recruited the clinician researchers belong to a memory clinic and interested in the same topic. And in parallel, we created the survey and defined the primary activity. Then the survey was disseminated through the major international hubs, and the data collection started in 2022 and lasted until the end of the same year. And then we start to analyze the data. So we asked ourselves how we can collect the data. And we imagine a pyramid of participants involvement, starting from the project coordinators, then going to the national hub, coordinators from different countries who are in contact with other collaborators and colleagues within the same lab and with other in contact with other clinical services. And at the base of this pyramid, there are the professionals that work in the memory clinics, both the physician and psychologist who will be the respondents to the survey. And we have planned to collect a minimum of 30 responses per country. And finally, thanks to the great effort of all the signature members, we were able to reach the response from 18 countries. So, the clinical survey was structured as follows. A first section dedicated to the general information, background and commitments. A second part focused on the use of neuropsychological assessment in different memory clinics. And a third part focused on the use and knowledge of social cognition always in men in the clinical setting, and a final section concerning the utility of social cognition measure and the obstacle. Okay. 430 participants completed the survey. Of these, you can see that 62% were females, while 33% were males. And we can see, moreover, a good balance regarding the profession. In fact, 48 were physicians, while 52% were psychologists. And regarding the commitment, 70% were research, doing just research in clinical practice, 28% only clinical practice, and finally 2% only research. Okay, moving on, we investigated how are neuropsychological measures selected for the standard assessment. And you can see that 50% use a standardized internal protocol, 38 structure the neuropsychological assessment based on the clinical presentation, and an 11% relying on evidence-based protocol. Regarding how many hours are dedicated to the standard neuropsychological assessment, 47% of the participants take between 1 and 2 hours, 37% take more than 2 hours, and finally 11% less than 1 hour. Okay. Then we ask information about the neuropsychological battery for the baseline assessment, both for major and mild neurocognitive disorder. And for the major neurocognitive disorder, 46 participants answered no. And among all the cognitive domains, the social cognition was not investigated in the 96% of the cases. And as you can see, this percentage is far from the evaluation of the other domain. In fact, while social cognition is not reported in most of the neuropsychological battery, other domains such as executive and language are almost always present. And regarding the mild neurocognitive disorder, we have a similar scenario. In fact, 45 participants answered no. And here again, we can see that among all cognitive domains, 94% do not assess the social cognition at the baseline. Okay, moving forward, we investigated which social cognition measure are used in each center. And we asked to describe if the test is known and used, report here in green, if it is known but not used in yellow, and if it is completely not known in red. And the Ekman test represents the most widely and used test overall in the response sample. But also other measures, for example, the FOPA reading the mind in the eye, the mini C test represents a test that are generally known and used. And it is interesting to see that other measures generally known for research practice, for example, the self-monitoring scale and the interpersonal activity index are not known and fully used for clinical practice. And in the last section, we asked, which is the contribution of the social cognition for the assessment of neurocognitive disorder? As expected, most of the participants agreed that it is useful for differential diagnosis. But more interesting, they also reported the relevance on the detection of the new cognitive phenotypes. Then regarding the relevance to assess social cognition, even in this case, as expected, and also we already seen during the morning presentation, the majority of the participants agreed to assess social cognition in the behavior variant of frontotemporal dementia, the 92%. But not only in this condition, an agreement was found also for the primary progressive aphasia, for the typical of Parkinsonism, and in the end, for the non-amnesic mild cognitive impairment. And finally, regarding the presence of obstacles that limit the use of social cognition measure, 70% answered yes. And most of the participants agreed that the limited availability of measure, the lack of guidelines, insufficient time in the clinical setting, insufficient formative events represent the main obstacle that limit the use of social cognition. And we finally thought that there might be some differences between countries, and in the next slide we summarize the main obstacle per country in order to identify country-based needs. And this is disabled, that you can see different countries at the major obstacle. And the red visa represents when there is an obstacle, and the green cross represents when there is not an obstacle. And overall, all countries are agreed that there are sufficient neurobiological confirmation, but there is a lack of social cognition measure. And finally, insufficient time for the neuropsychological assessment and lack of guidelines are an obstacle for almost all countries, except for France and Germany. Yeah. And finally, taking together these results, we can say that in the future, with this initiative, we can highlight the importance of social cognition domain in clinics, increase the education for the assessment of socio-cognitive disorder in the field of clinical neuropsychology, and finally, to foster the communication between the research and the clinician. Well, thank you everyone for your contribution and for your thanks.
Thank you, Andrea. That's really interesting results. Do we have any quick questions? I know everyone's keen to get to lunch, but do we have any quick questions about the results or?
Maybe one wants you to lunch.
Yeah, or maybe people want to ponder the results and then ask questions later. So, so I just want to thank everyone who has been part of this session. Thank you so much.
Thank you.
Okay, so thank you again before. Thank you, everyone online. For the panelists, we would ask you to come back on the same link at 2 p.m. So we can start with the Delphi procedure. To the others, thank you again for being with us today. For all in presence, before having lunch, we would ask you for a favor. Inside the shopper, there's a T-shirt, this one. We would like, since it's the first event, we would like to take a picture all together with the T-shirt. Okay, you can put it over your shirt. It's not important, just to have a picture all together. Okay. Ah, sì, vai, ma se posso dire. Okay. Before lunch, yes. If you want, there's a toilet over there. Okay.
Grazie molto quelli a casa e salutiamo. Saliamo quelli a casa. Vediamo lì, no aspetta, perché sennò quando...
So for those who are so online, so we will start in 10 minutes. We are waiting the panelists here in present. So.
Grazie Andrea, buon pomeriggio, good afternoon, welcome. Confusing to be in Italy at an international congress. So we start again with the afternoon session. Now, Claudia May, researcher in neuropsychology at CIMIC in Trento, will introduce you to the meta survey on socio-cognitive tools across countries. And Claudia, the floor is yours.
Thank you, Marina, and good afternoon, everyone. To start the afternoon session, we have planned an activity for panelists that we have called the meta survey on socio-cognitive measures across countries. As shown in the presentation of the results this morning, we have seen that the Ekman test, the FOPA test, the reading the mind in the eyes, and the UEC are the most known and used tools of social cognition across countries. However, these data are the most represent the general scenario, but when we had a look at the data for single countries, we found relevant differences in the use of these measures. Just to give you an idea, when we explore the most known and used tests for each country, we noticed that the Ekman 60 Faces is the most known and used instrument in Brazil, Italy, Portugal, and Spain. FOPA test is the most known and used in South America, Netherlands, UK, and Switzerland, the UEC in France, and the reading the mind in the eyes in Greece and UK. As you can imagine, these differences may represent an obstacle for the harmonization for assessment in clinical settings. The first step to solve this issue is to have a clear picture how which measures are available for clinical use and in which country. And this is what we would like to do in the next 15 minutes. This activity will give us the possibility to provide an open database on the availability of tests for clinical use in different countries, have a picture of which tests require an effort to develop normative data in single countries, and in future perspective, define which tests can be used for multicentric clinical studies. For the activity, the panelists here can scan the QR code. For the other, we send a link on chat.